Okay, can everyone hear me okay?
Yes.
Yes, doing okay. Okay, perfect. Well, my name is Cassandra Clayborne. I am a faculty family medicine doc over in the Eastern Panhandle of West Virginia. So I'm over at Harper's Ferry Family Medicine, if anybody knows where that is. I have been bestowed the topic of managing urinary tract infections. So we're going to be doing an update on those guidelines. And like she said, just go ahead and you can unmute yourself and ask questions or put them in the chat. Hopefully, somebody else will look at them because I'll forget that they're there. Um, so, just a little bit about myself. I am recently an attending physician, so it's been about 2 years. I did my medical training all in West Virginia. So WVU for medical school, and then spent my 2 years of clinicals out here in the Eastern Panhandle, and then did residency out here as well. So all in all, I've been out here about 7 years. I'm a mom of two. I have a 3-year-old and a 7-month-old. I'm passionate about education, geriatrics, and about community medicine. So I'm one of the people that does the home visits out here in the Eastern Panhandle. So enough about me. Let's go ahead and dive into urinary tract infections. So I'll be doing the key updates from the 2025 IDSA guideline. There may be some new medications that have been approved through the FDA. They're not included in here. So if you guys are using anything brand new, it's not going to make it into this PowerPoint here. Overall, my objectives today are to review and update the updated complicated urinary tract infection definitions, discuss empiric antibiotic selection, review that IV to oral transition, examine treatment duration recommendations, and apply the guideline recommendations to community practice. So, all right, here's our little West Virginia. Um, After this session, I'm hoping that you all get out of this being able to differentiate uncomplicated versus complicated urinary tract infections, because that has definitely changed in these 2025 guidelines. Be able to apply the IDSA 4-step empiric treatment framework. Select appropriate oral and IV antibiotics, and determine when that transition to PO is appropriate, and then utilize antimicrobial stewardship principles as much as possible. If anybody works closely with a clinical pharmacist, you probably have already been lectured about this multiple times. So, what's new? Um, what I can say to distill it all down is that previously the classification was a complicated, kind of convoluted um, gumble of words. So it was an acute cystitis in an afebrile, non-pregnant, premenopausal woman with no diabetes and no urologic abnormalities. That was an uncomplicated UTI. That has luckily switched over to an afebrile person with an infection confined to the bladder. So just a lot easier to remember. You need a person and an infected bladder. That's it. That's an uncomplicated UTI. No systemic symptoms or anything. In the old classifications, we also had uncomplicated UTI, the acute pyelonephritis, as well as complicated UTI, and those were all kind of different tiers. In this new classification, anything that isn't an uncomplicated UTI falls into the classification of a complicated UTI. So any infection beyond the bladder, that's whether it's in women or in men. So something that it can be noted is that previously a infection confined to the bladder in a man or in a male would be under that complicated UTI diagnosis, and it no longer sits there. So the complicated UTI encompasses pyelonephritis, any fever or bacteremic UTI, catheter associated, or prostatitis. That's not really covered as much in these guidelines, but there are some pretty common principles or overlapping principles with that. So you still start with an empiric therapy that covers gram negatives. You want to start broad. If you have any urine cultures that are recent, you kind of use that to guide your therapy. And then as you kind of get the information back with the culture, you can start to narrow things in down. So complicated. So we kind of already talked about how the previous definition was much more complicated than this one. So this is that new classification approach. Again, infection is limited to the bladder. There's no systemic symptoms in that uncomplicated. Complicated can encompass that bacteremia, sepsis, any type of hardware in there, the catheter, stent, nephrostomy, anything that moves beyond the bladder in the upper tract. So things that used to help define complicated UTI that no longer do are male sex, diabetes, immunocompromised patient, and old age. And yes, even patients with underlying urologic abnormalities, they can now have an uncomplicated UTI. So just a little bit of shift in thought there. So you can take just like a quick second to read these really quick. This I want to be able to place in their respective categories of either belonging to complicated or uncomplicated UTI. So we have dysuria, fever, flank pain, frequency, suprapubic pain, and urinary obstruction. So probably don't take too long. But here we have our kind of systemic features that fall under that complicated category. So the fever and the flank pain. And then everything else are just symptoms of the cystitis itself or urinary tract infection. So dysuria, frequency, suprapubic pain, all of those things still just fall under the uncomplicated, unless you add another symptom in, that'll stay an uncomplicated UTI. Did I hear something? No. Okay. All right, so selection of antibiotic therapy for these complicated UTIs. This is mostly what the bulk of the update is about, other than just that, reframing of what a uncomplicated and complicated UTI are. So I'm hoping to review the recommendations on these empiric antibiotics, understand the recommendation priorities, so why we're choosing one priority over the other with the empiric antibiotics, whether that's efficiency time-wise or stewardship with the antibiotics. Learning about the 4-step approach to choosing those antibiotic therapies and understanding when we de-escalate that therapy. So the initial selection, I kind of just broke it down. They have those 4 steps, so just added them all here, and you'll kind of, as we go through, see each associated with the slide up in the left-hand corner. So which one should initially be prioritized? We're going to apply our 4-step approach. So it always starts with assess the severity of illness. So really that kind of breaks down into sepsis, no sepsis. Evaluate the resistance risk factors. So what have they been resistant to in the past? What are local resistances, things like that. And then review patient-specific factors. So that might be age, allergies, things like that, pregnancy, and then use the local antibiogram if available. I know that is not available everywhere, so we will if we have it. So the first kind of 3 steps in the approach promote individualized therapy. So that will be more kind of patient-specific. That'll change based on which patient you're looking at. And then this last step kind of promotes better stewardship and reduces over-treatment, and hopefully helps with the antibiotic resistance. So assessing a severity of illness, we have our SOFA here. So one of our tools that we use, whether you use the quick SOFA or just the regular SOFA, you're going to need greater than two or two or more criteria that is suggesting a poor outcome, which will then determine a complicated UTI. So first question you ask yourself is this patient septic? So we're evaluating for organ dysfunction, hypotension, and elevated lactate. So if yes, then broad spectrum antibiotics. We kind of know the drill there. Anytime we do the sepsis campaign or go through those steps, we're doing the broad spectrum antibiotics, we're doing fluids, all the things. So that still holds true here. And then if not, then we can go ahead and just start with a narrow therapy, kind of monitor symptoms, monitor patient status, and then kind of decide whether or not we change our antibiotic or need to broaden our spectrum from there. So I just put the little empiric antibiotic list. So all the things we use in the hospital. So third or fourth generation cephalosporins, carbapenems, piptazo, and fluoroquinolones. And we'll talk a little bit more about whether or not we're using the fluoroquinolones as firsthand. Let's see if this wants to change. Okay, so step 2, we have our evaluate resistant risk factors. So is there any risk for a resistant organism? So we're looking at prior urine cultures. And a lot of times we kind of take a look back into the distant history. Studies show that really the last 3 to 6 months are the best indicator of what that patient will have at that time. So recent hospitalizations, recent antibiotic therapy, especially fluoroquinolone use, prior ESBL history. So just knowing whether or not they have multi-drug resistant organisms, recent fluoroquinolone exposure, and the indwelling urinary devices, because that changes just how we treat it, how aggressively we treat it as well. Okay. And then step 3, we're reviewing patient-specific factors. This is kind of what we talked about before, whether we're pregnant, whether we have allergies to any of the medication, whether or not we can clear the drug, so renal function. We'll have to look at the med list to see about QT prolongation risk, and then whether or not the patient can even tolerate oral medications. So that'll dictate whether we're doing IV or oral, depending on the severity of the UTI. So just some quick tips. Like I said, the urine cultures in the past 3 to 6 months are probably more helpful. And then we're trying to avoid the fluoroquinolones if they've had prior exposure within 12 months, if possible. Okay, so last step in our 4-step process here is to use the antibiogram. So if it is available, these can be kind of hard to find, and especially in areas that are more rural or secluded, this might be a little bit more difficult. The recommendation is to kind of find a local hospital or a region that is closer to you and use their antibiogram. So if there's one available, then yes, we use that to guide our antibiotic therapy, and that just tells us about our local resistances. I'll kind of give you an example of the antibiogram if you're not familiar with it. And then if the patient is in septic shock, it just tells us which one of those we're going to use. So the antibiogram will let us know, is it highly susceptible to antibiotic A, and you want that to be greater than or equal to 90%, so that you're really kind of getting the best bang for your buck on that IV antibiotic. So if they're in septic shock, obviously timeliness is the major factor there that's kind of driving that decision, versus if they're not septic and their vitals are stable, then we can kind of lean more on our antibiotic stewardship to make sure that we're making the right choice for the patient and decreasing resistance risks and adverse events and such. So I am a child of the 90s. So you have your Pokemon card here. This one is our most common organism that causes UTI, and that's E. coli. And then obviously they have the extended spectrum beta lactamase that gives us all of our complications. So this is resistant to many penicillins and cephalosporins, so it definitely makes it a little bit harder to treat. That's why it earned itself a playing card. So largely we're covering for gram-negative organisms, and that's because these ones tend to cause more of the UTIs, although there are obviously some gram-positives. Generally with the staphylococcus, that usually seeds from like a bacteremia and things, but that one is in there as well. Let's see here. Okay, so here's our antibiogram. This one is not from like a local hospital or any healthcare facility. I just wanted to kind of give you guys an example of what one looks like and kind of what it entails. So what it's including is you'll have your antibiotics in that first column. So that's just telling us what kind of things we've been testing or what kind of antibiotics that we use. And then as we're going down or going over, the column number 2 is just number of patients with each of those organisms. So 37 with E. coli, or 31 with the Proteus, 17 with Staph aureus. So that's all of those patients that grew that organism. And then all of the columns beyond that are telling us like all of the different tested antibiotics on that particular organism. So they're not all filled out. I think we've all probably gotten frustrated with looking at a urine culture with susceptibilities that is missing some of the antibiotics that we want to use. So not every antibiotic is tested on every organism, but there are multiple, and usually they span all of the different antibiotic types. So in the yellow that they have highlighted here, this is kind of just telling us that there's insufficient data there to really be able to say yes or no on a recommendation for whether or not that antibiotic may work well. So those are for that. And again, there's no kind of like single statewide antibiogram. You should be looking to kind of like local areas to try to figure that out. I went ahead and printed it out because I couldn't figure out how to put it in here because I needed a West Virginia University PC, but I have my local antibiogram here. And this one is for Jefferson Medical Center. So even 35 minutes up the road is Berkeley Medical Center, and that one has a little bit different of a antibiogram. So trying to figure out how to find that source and where to find that source. All right, and so this is one of the figure or the tables from the guidelines, and it just had a lot on it. So I wanted to go ahead and add it so you all had a good look at it. You can see in there that it already has our 4-step approach up at the top. So that's that severity of illness, risk factors for resistance, patient-specific considerations, and then the antibiogram if septic. So they really use the same medications, whether the patient is in sepsis with or without shock. And then a lot of times if they're in fluid sepsis, especially if they're in shock, we're using IV antibiotics. That patient is not taking an oral antibiotic. So these are kind of all of the same. And then if the patient is stable and does not have sepsis, then we can try oral medications like fluoroquinolones or Bactrim or trimethoprim sulfamethoxazole. They do have some alternatives basically the general idea is that we want to use our older drugs and we're kind of holding on to our newer generation drugs if possible. And that shows up multiple times throughout the guidelines. So here are IV antibiotics and their dosing. Not a whole lot to say here. It's more just for completeness sake that this is in there. Generally, we throw ceftriaxone on there if we see someone come in with a UTI, but there are a whole host of things that we can use, and those have those different organisms that they work against. So whether you're looking at a pseudomonal or not is kind of one of those bugs that we tend to use a specific antibiotic for, or a different class of antibiotic for. So for selection of the definitive antibiotic therapy, this is kind of getting us from our broad spectrum, patient just came in, we're not really sure what we're working with, to kind of curating that down into something that is hitting a specific bug effectively. So the results are in. So should we be using this definitive therapy as soon as we get those urine culture results back with the susceptibilities? And the long and the short of it is yes. We want to be able to narrow down as quickly as possible. So once we identify the bug and the susceptibilities, we want to go ahead and narrow that therapy to a definitive effective antibiotic. And the effective antibiotic is just the antibiotic that it works well against the causative organism without too broad of a spectrum. So when can a patient be transitioned from IV to oral antibiotics? I feel like this is something that we kind of know intuitively. Is the patient getting better? Is kind of the big thing. If they are hemodynamically stable, if the patient is improving and doing well on the antibiotics that we have going, if the patient is finally able to take something by mouth. These are all reasons that we can move from that IV antibiotic to PO antibiotics. The other thing we need to consider is, does the PO antibiotic reach therapeutic levels in the bladder or wherever the tissue target is? So major aims for this isn't just that we don't want to do IV antibiotics. It's to reduce those IV catheter-associated infections, general adverse events, costs, length of stay, resources as well. So the little schematic to the right is all of what we just talked about. Are they improving? Yes, then we can go ahead and switch to orals, and then we have a short duration of antibiotic therapy versus are they not improving? We need to kind of do some investigation. Are we using the correct antibiotic? Are we treating something? Are we missing a different infection? And then kind of we need to move that course out because obviously it's not effectively controlling the infection. Okay, so here are those oral antibiotics. Again, I don't feel like I need to go through the dosing necessarily, but something that is great here is that oral absorption versus urinary excretion. So just kind of knowing what medication reaches or is absorbed well enough to exert its effect. So levofloxacin is obviously is a great one. It's not the one we reach for first usually, but it is a great oral antibiotic for UTIs. Same with Bactrim, that's 70 to kind of 90% oral absorption. And then this urinary excretion. So is it getting to the tissue where it needs to exert its effect? And so the ones that we commonly use, Bactrim, levofloxacin, are higher. Greater than that 80% is kind of where you want to be. And then you have some of your third generation cephalosporins that obviously also reach high enough urinary excretion and oral absorption. Okay, so in patients presenting with a complicated UTI with a clinical response to therapy, should those total duration of antibiotics be prolonged greater than 7 days, or should it be less than 7 days? And I think we all have that 3 to 5 days, or 7 days, 10 days to 14 days, where you have kind of those questions of the duration of antibiotics. And the guidelines say really 5 to 7 days, or 7 days or less, or tends to be enough. You can get a little bit shorter, that 5 to 7 days with the fluoroquinolones, but generally if they're non-fluoroquinolone antibiotics, 7 days it is good. And that 7 days is going to start from the first day of effective antibiotic therapy. So if you had to switch over because you weren't controlling symptoms well, or like the patient was not improving, then that timer starts over again for that 7 days. So longer durations are going to be that suspected prostatitis. So that tends to be like 2 weeks to 4 weeks generally, if you have poor source control, like we talked about, and then delayed response to the antibiotics. So a lot of times we look at when did they receive that first dose, and when did they start getting better, and then kind of marching out 7 days from that. Okay, so here are some key stewardship principles. What doesn't kill you mutates and tries again. So we want to de-escalate when the cultures return. So just kind of narrowing down that spectrum of antibiotics. Avoiding unnecessary carbapenems, so just trying not to stay too broad for too long. We want to shorten the duration of antibiotics when possible. So instead of having this kind of long drawn out course, knowing that 7 days from a start of effective therapy is adequate in most cases, unless you suspect something else. Reducing fluoroquinolone overuse, avoiding treating asymptomatic bacteria, obviously unless in like a pregnant patient. So aims in all of that stewardship is to resistance prevention, lowering adverse events, and reducing C. diff risk, which would be another adverse event, but the specific one that we look at. General takeaways, men can have uncomplicated UTIs. I feel like that's a big change in just kind of thought process. We want to use the 4-step empiric framework to guide our decisions. So kind of looking at all of those different components to direct our antibiotic therapy. Transitioning to oral therapy as early as possible, and not kind of hanging around on the IV to increase those like IV catheter associated infections or costs and things like that. And then hopefully decreasing length of stay. And then stewardship should guide every treatment decision, but looking at the patient's clinical context kind of determines whether or not stewardship is the driving force of that decision, or kind of takes a backseat until a later decision into narrowing your antibiotic. All right, and that's what I have for you guys. I don't know if you have any questions or are ready to go through the clinical case.